Hi, everyone. Thanks for joining us today to talk about unlocking the potential of plaque analysis. I want to thank especially SCCT for hosting us. I'm Tim Fonte, HeartFlow's Chief Technology Officer, and I'm joined today by two really wonderful speakers, Dr. Wes O'Neill, who's the Director of Cardiac CT Imaging at Cone Health. Dr. O'Neill's been involved in a number of HeartFlow studies, including Smart CT, Reveal Plaque, the Decide Registry, and I think you'll see brings a very real-world and hands-on perspective to the use of these technologies. And then Cara, who is HeartFlow's SVP of Market Access and Reimbursement, and she's going to talk about all the news and recent developments with reimbursement around plaque analysis. I'm going to kick it off with a bit of overview of our technology and some of the latest evidence. If you have questions, feel free to drop them in the Q&A section, and we'll get to questions at the end. So first, the overall HeartFlow platform, this consists of three main tools, and we're going to focus a lot on plaque analysis today, but for the overall context, the roadmap analysis is designed to provide stenosis information and visualizations to aid in interpreting CT, and it's been shown to help make CT reading both more efficient and more consistent. The plaque analysis, which quantifies plaque throughout the coronary arteries and characterizes it by different plaque types. And you can think of plaque analysis as giving this long-term assessment of patient risk and helping inform preventative therapies. And then FFRCT analysis, which provides very precise lesion-specific values of physiology and kind of complementing the plaque analysis helps provide that more near-term assessment of does a patient benefit from revascularization or not. And then we'll speak a bit about how all these tools can come together to help with not only diagnosis, but also planning treatments. This shows the latest update to HeartFlow's product. This is an interactive experience that now brings together everything we just talked about, the patient's anatomy. You can see a 3D model in the left side of the screen. It can display both regions of plaque as well as the lesion-specific FFRCT values. And then the ability to scroll through that data and obtain down a vessel at any specific location, both the FFRCT values, the degree of stenosis, and in the upper right, you'll see images of the cross-sectional view of plaque labeled by color of where plaque was found and quantified, whether it was non-calcified or calcified plaque. You can see we're right in a very large non-calcified region of plaque right here. So this brings new ability and insight into how all this information comes together and to understand plaque analysis information. All of this, of course, for HeartFlow is built on a base of quality, and we have the only product that's had prospective, multi-center and core lab adjudicated validation against invasive standards. We did that originally for FFRCT compared to invasive FFR, and more recently for this plaque analysis we're talking about today, where in over 400 lesions, this was compared precisely to IVUS to have a 95% agreement for plaque volume. This is especially important to do these prospective type of studies with AI-based technologies and give them a new, fresh set of data to be evaluated on so that you can understand the performance. I'm going to talk a little bit about the workflow as well. So how does all this information come together? Part of the HeartFlow One platform is what we call the direct workflow, which means every coronary CT gets analyzed. And we've really designed this specifically to serve the clinical needs throughout assessing a patient. So upfront, roadmap is provided. That's meant to help guide coronary CT reading, as we talked about before. So it's available on every coronary CT, helping identify stenosis or regions of concern. Then the product allows you to select when you want plaque, FFRCT, or both on any given patient. And the reason that's important is, Cara will talk about this later, there are patients where you only want FFRCT, there are patients where you only want plaque clinically, there are patients where you want both, and there are now codes separately for FFRCT and plaque. So we wanted to ensure we had a product and a workflow that would enable you to not only order, but also complete all the steps of billing these products independently or together when all are used. I'm going to talk about some of the latest evidence now. How does this all come together clinically? This is really exciting data. It was presented at TCT recently, 7-year follow-up data from the advanced registry that looks at both FFRCT and plaque analysis over a very long follow-up for these patients. Uh, First, I'm going to talk about the FFRCT aspect of this. And what happened in this study was patients based on FFRCT were either treated or not for revascularization. So the blue curve at the bottom shows those where the lesion-specific FFRCT was negative. There was no lesion that warranted revascularization. These patients had very low event rates out to about 3 years, and then you can see some increase over time. The yellow line is patients where complete revascularization was performed based on FFRCT. So every lesion that was positive was revascularized for each specific lesion. And you can see those event rates actually end up quite similar to the normal FFRCT. And then the red line are incomplete revascularized FFRCT lesions. So at least one lesion with a positive FFRCT was not revascularized, and we can see there's a hazard ratio of over 2 compared to complete revascularized patients. So first, I think this is very compelling evidence and important from the notion of it really benefits patients to identify lesion-specific FFRCT and actually revascularize those lesions. We get better outcomes for these patients. But the interesting part here for today's discussion also relates to plaque analysis and where does FFRCT and plaque complement each other in these different scenarios. So the investigators broke this down by those 3 different groups. For the incomplete revascularized patients, where some lesion wasn't actually stented, we see that FFRCT dominates. So plaque burden outcomes look relatively similar because there were very focal lesions that had a drop in FFRCT that were left unrevascularized. Outcomes are driven more by FFRCT in this group. For the patients where there was complete revascularization, we now see the opposite. FFRCT has less impact over time, but there's a hazard ratio of 5 for patients with higher levels of plaque burden, even after having complete revascularized FFRCT. So this gives us really interesting insights on the residual risk of these patients after revascularization. The plaque burden is complementary and helps describe that there's more residual risk in these patients with high amounts of plaque. And we see something similar on normal FFRCT. If you recall, these patients had very low event rates out to about 3 years, but then started to have some events. And we see a hazard ratio of 2, where after about 3 years, higher amounts of total plaque burden yield more events in these patients. So again, this notion of residual risk, even in normal FFRCT patients on a very long time horizon. So we think this is really interesting to think about how to inform decision-making, preventative therapy. There's an ongoing registry now, a very large registry of enrolling over 20,000 patients, multi-center registry where we will look at changes in medical management after HeartFlow's plaque analysis, biomarker changes, outcomes over time, and we hope this will bring a lot of new insights like the data I just shared on the real-world prospective evaluation of these technologies. And then last, I just want to share about this topic of planning that we talked about up front. So HeartFlow has been involved in this whole field of how CT can be used to guide coronary interventions for a number of years now. We are part of the P4 study, which is a randomized study led by Carlos Collette looking at CT-guided strategies versus IVUS. FFRCT is used by many in the cath lab to understand lesion-specific revascularization. We're now seeing a number of great courses evolve on teaching these techniques. And I'm going to share a case from Dr. Sandoval at MHI from one of these recent courses. And this shows the product that I showed earlier. On the left, you see a lesion-specific FFRCT of 0.72 right in the mid-LAD. So definitely positive, very focal lesion, pressure drop of about 0.2 for a delta FFRCT. And then using this product, they were able to identify and look at the plaque burden down the vessel. And in particular, right at that location where the lesion is, there's very complex calcium. You can see it in the right in blue, almost completely surrounding the lesion. And this brings together the patient's anatomy, the stenosis, the plaque, and FFRCT all in one picture, all before the procedure was done. So as Dr. Sandoval went into the procedure, he was able to know what projection do I want to use? How should I look at this vessel to have the optimal view of it? Because of the plaque information and seeing calcium so precisely up front, he knew he wanted to do lithotripsy to prepare that calcified lesion for stent placement and then knew exactly where the stent should be placed based on the physiology and plaque information. That was a very successful procedure, confirmed with both OCT and FFR as part of the live case. But I think really shows this new world where instead of going in to a procedure like this and figuring it out after the angiogram, all of this was understood before and led to a lot of confidence in doing the procedure. So thank you so much. I'm going to hand it over now to Dr. O'Neill to talk about his experience.
Thanks, Tim. Happy to be here. Thanks to SCCT and HeartFlow for sponsoring this. So I'm going to give a little bit of talk about how we have used the tool in practice at our institution in Greensboro, North Carolina at Cone Health. So Tim showed a lot of data, and I do like to kind of show some more data just to put a frame of reference for our discussions, especially with the case-based discussion I'll have a little later. But really, the plaque tool itself, the complete quantitation of calcified, non-calcified, even low attenuation plaque is important. And this is data from Scott Hart, which does show that patients with high total plaque volumes above a median value of 238, 250 or so really do have higher event rates. And this was shown to be prognostic and a strong predictor of incident MI, irrespective of CV risk score, your calcium score, or even stenosis severity. So really you can get a lot of information from this total quantitation. Also, we've really learned, low attenuation plaque, the low attenuation with Hounsfield units less than 30, they really are the strongest predictors of MI. And these are the vulnerable plaques that we're so used to talking about in cardiology. And Scott Hart, when they reanalyzed some of these data sets, they really showed that with your low attenuation plaque burden or your volumes over 4%, that is the strongest predictor for incident MI. So the overall total quantitation can really just give you a lot of information for your patients, and we've seen that in our practice. Tim did touch on this briefly, but for a frame of reference for case discussion, it's very important. This is data from advanced decay, which does show you that residual risk that you do have. And I like to keep it simple just because that's going to keep you in a good frame of mind work when you're taking care of patients, especially when you're interpreting FFRCT values or even plaque data itself. But when you look at this data here, it just shows you that most adverse events in patients with abnormal coronary plaque, these are the two bottom curves, which are blue and green, FFRCT negative, plaque negative versus one that's plaque positive. You really see the separation of curves later. So abnormal plaque events are going to occur later downstream. You want a good preventive approach for these patients. You want to do what's right for them. FFRCT events occur early. So as Tim mentioned, if you have abnormal FFRCT, abnormal physiology, we know those patients benefit from revascularization. But we're even starting to understand with data from advanced decay and other studies that even plaque itself with FFRCT positive lesions is important. You do see a synergistic effect. So if you look at the red curve, even patients with abnormal FFRCT and abnormal plaque are able to get more important data or more prognostic information than you get with either tool alone. So I think that's just really important frame of reference when thinking about how to incorporate plaque at your site or your institution. So Tim mentioned the side registry, which our site's involved with, and this is a large real-world registry. Nearly 20,000 patients will be recruited. And the whole idea here is to look at the plaque tool from HeartFlow in more detail and determine how it changes management. These are several arms of the study, which we don't need to go through today, but really the idea is to look at what patients have happen when they don't have plaque information available, when they do have plaque available information at a delayed time point, meaning they've already had their CTAs done. Does it change your management? We also are looking at patients prospectively, meaning they've had a CTA, they have the plaque information up front, and to see what happens. There's a stress test arm in there to compare those patients, as well as patients who've had PCI or even asymptomatic patients. Most patients at our site are going to have stable symptoms. That's the most who are referred for coronary CT angiography, but there are some sites who might do it in asymptomatic patients. But the idea here is to get a lot of information on this, a lot of data and outcomes to see how this changes our management for our patients. Part of the DECIDE registry has incorporated a suggested treatment algorithm from HeartFlow and other leaders in the field, particularly in the lipid field or lipid space. And basically, this just kind of walks you through the suggested algorithm for what you do with the plaque volumes that you get. It'll stage them mild, moderate, severe, extensive. You'll actually will get a graded level there. You'll actually get biomarker goals for these patients based on their total plaque volume. There's even treatment options or suggested algorithms. But I think this has been really important for our site as we participate in the DECIDE registry, as well as when we start to think about how to use the plaque information to care for our patients. There's even the implementation, and you'll see incorporation of a nomogram. There's a nearly 11,000 patient study from HeartFlow, which puts kind of the plaque volumes in percentile so you can see if someone accelerated or not. And that's really useful to determine, are you going to upstage someone? Meaning you could have mild total plaque volume, but you're accelerated, you're in the 60th percentile. So you probably are going to want to treat that patient a little more aggressively and up-classify them to treat them in that moderate range. Also, risk enhancers are extremely important in CV prevention. These can also be used to kind of up-classify a patient to maybe change that risk category. And there's some other considerations about GLP-1s. Those are becoming more important as we think about a preventive approach for our patients, and lifestyle modifications are important. But this really has given our group a frame of reference, and DECIDE will kind of shed more light on this. And as the data evolves, hopefully some of these algorithms will be more available and more widely accepted in cardiology. So let's just walk through some cases and kind of how we use the plaque tool, how our sites use it, how we've seen it valuable. And these are all patients who participated in the DECIDE registry. So case one, a 60-year-old female, hyperlipidemia and chest pain, possibly cardiac, was kind of what was reported by the referring doc for the coronary CTA. The patient had a very strong family history of MI. Dad had an MI at 50. The patient had a calcium score 5 years ago, value of 0, deemed to be low risk. We hear this not too uncommonly in practice. These are the lipids shown here, an LDL cholesterol of 91, elevated triglycerides. And this patient was already on Lipitor 20, and that was the LDL achieved, and that was a fasting lab. The triglycerides were still elevated. The patient does smoke and really does not exercise. All of the anthropometric measurements, blood pressure within limits for this patient. So let me just walk you through the coronary CT data set from the anatomic assessment. These are the curved CPR images, or the curved planar reformatted images from the CT data sets. And just walking you through, you really see mild disease in the proximal LAD, kind of mixed density plaque. You see really nothing in the left circumflex. And in the RCA, you do have moderate non-calcified plaque. And then you do see, as highlighted in the red arrow and the blue arrow, there's low attenuation plaque, Hounsfield units less than 30, kind of this vulnerable plaque that we worry about. It was sent for FFRCT, which was negative, which is shown here with a value of 0.84, and the LAD was negative as well. And then this is just the plaque tool for that patient to kind of go through how you can look at the plaque in a more meaningful way. And this will just walk you through what Tim showed you, and you can look at FFRCT overlaid on the plaque. You can scroll through and see where the plaque is, get a good cross-section of it, see where the calcified, non-calcified, in this case, as you see the low attenuation plaque. You even get a marker of stenosis severity in FFRCT. So from our standpoint, you really can get a lot of information from one user interface, and it's just a tremendous amount of data for you to treat your patients, to know what you're dealing with and how better to treat them. So just to walk through the plaque case, or what the quantitative data showed, this patient had a moderate plaque level with a total volume of 135 millimeters cubed. They did develop over that past 5 years calcium score 0, now with a total plaque volume that's calcified of 5 millimeters cubed. But overall, the majority of this patient's plaque is non-calcified, 96%. And they do have a good amount of low attenuation plaque, 7%, kind of above that 4% threshold from Scott Hart. When we put this into our calculator, this patient's in the 67th percentile, above the 50th percentile, kind of accelerated for this patient. And what we did with this patient is, when you got the plaque data, you get non-obstructive CAD on your coronary CT data set. What do you do with it? You have a calcium score value. We kind of know how to handle that. But how do we incorporate total plaque volume into that? And I think that's what the plaque tool is allowing us to do. We now know this patient had a moderate plaque level, but they're above the 50th percentile. They have some risk enhancers. They're smoking, a very strong family history. This is someone you're probably going to want to treat very aggressively in that severe category. This patient also has low attenuation plaque. So with this data available, the patient was seen back in the office. LPA was ordered, which is becoming very important, we're learning. The LDL goal was determined to be less than 55, given all the high-risk features for this patient. Aspirin was added. They actually were referred for PCSK9 inhibitor therapy. Again, they were on a moderate intensity statin with an LDL about 117. They're really probably not going to get to this goal on that alone. So they were referred for PCSK9 inhibitor therapy, especially with the elevated LPA. And icosapent ethyl was added given the patient's long-standing history of difficult to control triglycerides. So really, a strategy was really tailored to this patient on the individual level based on the plaque data that we had. So case 2, another example of things you'll see in practice and how plaque has helped us as a site. 61-year-old male, hyperlipidemia, hypertension with possible cardiac chest symptoms. Family history again of MI at age 55. This patient interestingly had a coronary calcium score the year prior, 486, 89th percentile accelerated. Here's the lipid profile here, which shows an LDL cholesterol at 117. And this patient already is on high-intensity statin at 20 milligrams of rosuvastatin and aspirin 81 milligrams daily. The patient exercises routinely, 4 to 5 days per week, pursues a moderate or a proper diet, doesn't smoke, and alcohol consumption was rare. So this walks you through the coronary CT data set that we got for this patient, just walking through the curve planar reformatted images here. For the LAD, minimal mixed density plaque was noted in the LAD and circumflex. In the RCA, the patient did have mild mixed density plaque in the Prox RCA. And this patient actually had their CT performed before plaque data was available through participation in the DECIDE registry. So the plaque data was made available at a later date to the clinician. But the initial strategy had already been decided upon. The patient was recommended for medical management. They did not recommend to go to the cath lab. An LDL goal less than 70 was decided. However, there really was no change in management. The patient still remained on aspirin 81 milligrams daily, as well as rosuvastatin 20. And I think we see this a lot in practice, non-obstructive disease. Yeah, there's calcium, but how do we go about this in an aggressive manner, or how can we tailor that treatment strategy for this patient in a more meaningful way? And I think that's what plaque helped with this case. And this just walks you through the interactive analysis. It does show you FFRCT, although that was not sent for this case. It is available as a test case. But it shows you can walk through, you can see where the plaque is and the plaque itself. You can look at the cross sections. You can see the calcified, the non-calcified plaque. And you can really get more meaningful data for your patients. And I think from a reader standpoint, this does streamline your reader day. You have FFRCT data there. You have stenosis markers there. You have all of this at your fingertips, and it really can help you get that data and visualize it in a very meaningful way. And just to walk through the patient's quantitative plaque analysis, this patient had extensive plaque, 820 millimeters cubed. When you look at the breakdown, I've highlighted some of this in the box. 13% of this patient's plaque was calcified. This patient had a very high calcium score, 486 the year prior. But there's so much more. This is the tip of the iceberg, and this is a good case example of that. This patient has nearly 87% of his plaque is non-calcified. So much of this plaque is unaccounted for with a calcium score test. You really are not able to tailor your risk or maybe your treatment strategies for patients in these categories, and this is a good example of that. He had about a 1% low attenuation plaque, not above that threshold, but still makes you wonder when you see that. This is the nomogram. This patient was in the 77th percentile, above that 50th accelerated. So a new strategy was chosen with the plaque analysis. Like I said, this patient's CTA data set had already been decided upon. The management strategy was there, and the plaque data was actually made available about 90 days after the CT data set to determine would the provider change their management. And they overwhelmingly did here. You know, just walking through 87% non-calcified plaque, the majority is plaque we did not account for in the calcium score test. An LDL goal now was decided in that extensive range, very accelerated percentile-based score to get his LDL less than 50%. He was kind of already on high-intensity statin, not even getting close to this, so he was referred for PCSK9 inhibitor therapy, and actually LPA was ordered. Again, that is becoming a more common test as we think about prevention and its influence on cardiovascular disease. You know, as our site has started to use more of the plaque tool, I just want to walk through some things where we start to think more about it. I think plaque is giving us a good frame of reference to treat patients in a more precise manner, to really look at the total plaque burden. But I think it's also starting for us, at least as a site, to ask more questions about cases that we do see. And this was a case I was reading 2 weeks ago, the high-risk non-flow limiting plaque. This is a patient here. If you look at the LAD, he's got a moderate osteal to prox LAD lesion. It's all non-calcified plaque, low attenuation. Hounsfield units are less than 30. The low attenuation plaque, if you will. It was sent for FFRCT, which was negative. And we see this not too uncommonly. And now we're starting to see studies like the PREVENT trial that has recently come out that looked at this. That's IVUS-based. High-risk plaque measures, prophylactic PCI to reduce events, which was positive. What do we do with these patients? And I think right now we're pursuing aggressive medical therapy, but as a CT reader, and now that I'm able to look at this in a very high fidelity manner, I'm starting to think about this more, especially as the plaque data continues to evolve about how we should approach these patients and what should we do. This patient was recommended for aggressive medical therapy, but I do wonder if things will change in the future. And this is a case that kind of highlights that as well. This was a case that we've seen through using the interactive plaque tool or the plaque analysis from HeartFlow at our site. Again, this is another case just to walk through. It shows you high-risk plaque that's non-flow limiting. So this patient actually presented to our hospital 6 months after his coronary CT with an out-of-hospital VF arrest due to an inferior STEMI, which is shown on the far right. You can see the EKG changes and the coronary angiogram showing occluded right coronary artery. But we looked back at this case. In this case, this patient had a coronary CTA for kind of a possible cardiac chest symptom 6 months prior. He had non-obstructive disease. He did have a lot of non-calcified plaque, actually all non-calcified plaque. This was another patient with a calcium score of 0 from a year prior who had this ordered for symptoms. And when you looked at his plaque analysis, it's all non-calcified, but he had a tremendous amount of low attenuation plaque, which is shown in the red circle in that prox RCA. It's FFRCT negative, but we really face this conundrum often, at least now using the plaque tool and looking at cases in more detail. And this patient showed up with an inferior STEMI due to his vulnerable plaque. So it wonders, what should we be doing with these patients besides aggressive medical therapy? Again, with the PREVENT trial showing a benefit with prophylactic PCI, I'm sure things will continue to evolve with how we approach it. And I think the plaque tool is set up to do all of this in a very meaningful way. And Tim mentioned this, and just to kind of take home what our site's seen with the experiences using the plaque tool, how we've embraced it in our practice. Yes, there's a lot of benefit in it in non-flow limiting disease, non-obstructive disease for CV prevention. It changes your management. It's going to change your strategy. You're going to have that tailored precision approach. But even our interventional cardiologists are seeing utility with the tool. And this was a case from recently, from the past month or so, of a patient with cardiac symptoms, underwent a coronary CTA. You can see he's got moderate severe LAD disease. It's mixed density plaque. It's very focal. There's calcified, non-calcified lesions there. But when we actually look at this under the microscope, or the plaque tool, if you will, you really can see this circumferential calcium, and you see the FFRCT here, which is abnormal. So this patient is likely going to benefit from revascularization. But now our interventional cardiologists are able to approach PCI or intervention in a more meaningful way. And I think that's just another thing that we've learned by using this tool at our site, is that it has uses in non-flow limiting disease as well as flow limiting disease. And it really can give you great pictures. And really, your ICs will really enjoy seeing this and planning out what they do. And we've started to do that as well. So really, to summarize kind of our approach, our clinical practice with embracing plaque and using it in our practice, we really are able to give you a full quantitation, or see a full quantitation of the plaque burden for the patient. Not just relying on calcium scores. You'll get calcified, non-calcified plaque, even this low attenuation plaque, which we still don't quite understand what to do with, but the data is coming and evolving daily. It really gives you a lot of prognostic information beyond stenosis severity, even with abnormal FFRCT, or if it's normal. The way I think of it, and the way when we talk to readers at our site, is this truly is a precision approach to risk stratification for CVD prevention. You're going to have more meaningful practice management for your patients. It's going to tailor your therapies to really target them in a more meaningful way that we've never experienced in cardiovascular medicine. So I think it's an exciting time for our practice and cardiology at large to really embrace the technology to see how we can improve the care of our patients. And the last thing, we still even see benefit in the cath lab, planning PCI, knowing what the lesion-specific characteristics are going to be. And that's really helped us grow as a site to really embrace the technology wholeheartedly in our practice. And I'll stop there and thank you.
Great. Thank you, Dr. O'Neill. That was incredibly insightful. So my name is Cara Santillo. I'm SVP of Reimbursement and Market Access at HeartFlow, and I am going to give a little reimbursement update for what is called AICPA. So for all those of you who love acronyms like I do, this is AI coronary plaque analysis. If you start seeing, there are policies that are being developed that we'll talk about in a minute, and you may see plaque analysis, and you may also see AICPA or AI coronary plaque analysis. That's an umbrella term for this category of technology that quantifies and characterizes coronary plaque, leveraging AI technology. So very rarely in the reimbursement world, and I've been doing reimbursement for a long time, do you get to say the terms, there's breaking reimbursement news, and it's good and it's very exciting. That is not common, but that is the case here. So we are going to jump into what all of this exciting breaking news is for AICPA or plaque analysis reimbursement. Just to get started, currently plaque analysis has 4 Category 3 CPT codes. Those 4 codes will be in place through 2025. The 0623T is the global code in the physician office or PFS setting. And then 0624T, 25T, and 26T through 2025 again are the technical and professional codes that are used primarily in the hospital setting and hospital outpatient setting. 0624T and 0625T are technical codes, and 0626T is a professional code for the interpretation and report. Now, the breaking news here is starting on January 1st, 2026, these 4 codes are going to be sunset, and a single Category 1 CPT code 75XX6 will be put into place for plaque analysis. And why there's still XX is what the exact code is going to be will not be released until mid 2025. So it's going to be a 7500 series code. They will be releasing kind of what the full the AMA CPT book will be released. That will include the final Category 1 CPT code, but it will be a AI coronary atherosclerotic plaque analysis code. So the 4 codes that we're using through 2025, those will all be sunset, and there will be one single code in 2026. The single code in the hospital will be billed as a global code, and then in the physician office setting or PFS setting will be billed as a global code, and then in the hospital, the TC modifier will be used to bill the technical component, and the 26 modifier will be used to bill the professional component. Moving away from coding, the other very exciting update for AICPA is that this year, the Medicare MACs, 5 of the 7 Medicare MACs have put in LCDs or local coverage determinations, so coverage policies for plaque analysis. And for those of you that know your Medicare MAC off the top of your head, Noridian, NGS, CGS, and Palmetto already have policies in place, and WPS as well, that will be finalized on either November 24th, so next Monday, or December 8th, which is Noridian. Those will go into place to allow for coverage for AICPA. All of these policies for those 5 MACs are exactly the same, and the overarching coverage criteria are that AICPA is considered reasonable and medically necessary for patients who are eligible under the CTA coverage policies. And then these patients have acute or stable chest pain and are at intermediate risk for CAD, or have evidence of CAD-RADS 1, 2, or 3 disease upon reading of the CTA, and that they're negative or inconclusive for acute coronary syndrome. Now, there are a couple other coverage limitations. They're at the bottom of the screen. I'd be happy, we can talk about those in greater detail, but really it's sort of, if it's CAD-RADS 0 or CAD-RADS 4 or 5, if they've had a recent MI, or if they're considered unstable. Those are kind of the general non-coverage limitations, as they're called. Now, for those of you who are up on your Medicare MAC policies, I listed out 5 of the 7 MACs. There are actually 7 MACs. So for the 2 MACs, which are Novitas and First Coast, in this handy dandy little map here, those are the very light blue. Those MACs, so covered lives for Medicare in those states, do not currently have a stated LCD. Those are covered on case-by-case coverage. We have heard that they are allowing for coverage in those MACs, but technically it's considered case-by-case coverage. And there may be additional documentation requirements associated with cases there. It's also important to note that, on November 24th, this goes into effect for WPS, CGS, NGS, and Palmetto, and then December 8th for Noridian. So it's important to note those dates as you're getting your programs up and running, and to review those local coverage determinations in detail prior to getting started. If anybody has any questions, HeartFlow has a team of folks that would be more than happy to help walk you through sort of what the coverage environment looks like. One question that we get frequently is, okay, this is Medicare. What happens with Medicare Advantage and commercial? So anything that's covered by Medicare, that has stated coverage by Medicare, has Medicare Advantage coverage as well. Sometimes it takes the Medicare Advantage commercial payers a few months to get all of their systems up and running to cover. But if it's covered by Medicare, it's covered by Medicare Advantage. Commercial payers are really still looking at putting coverage policies in place, and that will evolve over time. All right. So pulling this all together, the 3 tenets of reimbursement are coding, coverage, and payments. We talked about coding. We talked about coverage. Now let's get into payment. Tim, at the beginning of the webinar, talked about having products that can be used as and separately billed as the patient needs. So really, these have been developed and are coded, covered, and paid to be allowed for optimal patient care. So all 3 of these services have separate CPT codes and are separately billable from one another and may be used when reasonable and necessary. So it's very exciting. Another very exciting update is that the coronary CTA, which is billed using code 75574 this year for Medicare, in the hospital, per the 2025 final rule, doubled in payment. It went up 1 APC. And so you see the technical charge in the hospital was $175 for 2024. It's going up to national average of $357 in the hospital. FFRCT went up a little bit in the hospital, and plaque analysis for the 2nd year in a row, the national average is $950. It stayed exactly flat. So it's in that new tech APC that pays at $950. Of course, all of those are geographically adjusted depending on where your hospital is. These are national averages. And that's for the technical charge in the hospital. In the physician office setting, or PFS rule, CTA went up about 12% based on that charge. FFRCT went down a little bit. And for plaque, one of the things I did want to note in the physician office setting and for the professional payment, the payment is set by the MACs. So for Novitas and First Coast, those two MACs that have a case-by-case coverage, they do have stated fee schedule rates of $1,600 for that global charge in the physician office setting. The other 5 MACs, we are still awaiting fee schedule assignment, and we anticipate that will come out in the next few months as those coverage policies roll forward. The other thing to note in the physician office setting, and I will say this, we do a lot of work on the legislative side. There are likely to be updates before the end of the year in the positive way for the physician fee schedule on the Medicare side. There is doc fix legislation currently pending before Congress. They usually get to that mid to end of December. We'll likely see those rates updated slightly before the end of the year. So that's why there's an asterisk there. If you look at this right now, those are likely to go up a little bit when that doc fix legislation is passed. So with that, I'm going to hand it back over to Tim to lead us through the Q&A.
All right, thanks, Cara. That was wonderful. So we do have a few really interesting questions come in. Dr. O'Neill, I'll start with some for you. Do you change your prevention approach based on where the plaque is located, whether it's proximal or distal or the LAD or left main? How do you consider that?
Yeah, that's a good question. I think most do to an extent, meaning, we learned this from calcium scores. If someone's got a chunk of calcium in their left main or a prox LAD, you're probably going to be more aggressive. Right now our algorithms don't incorporate that, but I think anecdotally, I think every cardiologist who treats patients handles those things a little differently, especially left main and prox LAD. It may be one of those risk enhancers we see come through as we learn more about the plaque tool and the full quantitation as we go forward.
Oh, thank you. And then what drives the decision more for you? Is it total plaque volume or the more individual plaque characteristics you were talking about, or some combination? How do you put all that information together?
I think for us, and again, we all have that patient with a calcium score of 0, low attenuation plaque who has an event downstream from what you decided. And we're seeing that more frequently, especially as we go back and look at cases. But I think I start with an overall total plaque volume. What is that? That's my frame of reference with how I'm going to frame your preventive approach. And then from there, I will look at low attenuation plaque. Again, we're in this era, or there's new data coming out on what to do with these patients all the time. And I think it's asked a lot of questions, or we continue to ask a lot of questions about how to use it. But I do think when I see low attenuation plaque, that almost escalates what I would pursue from preventive therapy to really get that patient to a good goal. Look at LPA. I'm even, I think our site's really exploring inflammatory markers as this becomes online, especially with these vulnerable lesions. So to answer the question, really looking at it total and then kind of breaking it down to see if there's an enhancer there with how I might tailor the preventive approach for that patient.
Mm-hmm. Yeah, that's great. And then there was a question on whether we have age and sex-based nomograms for plaque like exist for calcium score. And I think you showed a couple of those. I don't know if we could go back to that slide.
Yes.
But...
Those nomograms are age and sex control. So it's going to be normalized to that when you compute your percentile. So yes, but race is not included in the data set currently, but it is age and sex controls, correct?
Great, thank you. And how about for the patient management? Are you showing the plaque analysis to patients? How do you help describe all of this to the patient?
Yeah, I do. I started to do that in practice. Actually saw a patient this morning, and I think what it does, it gives a frame of reference. Like, okay, this is, if you have non-obstructive disease, for example, this is your total plaque volume. This is your calcified plaque. Calcified plaque's thought to be good, stable, but this is the tip of the iceberg. You have a tremendous amount of non-calcified plaque. I think when you show that to patients and can give them that, hey, we now have an objective data point for your non-obstructive disease. I think they've been more likely to adhere to therapy and be open to some of these treatment options. We do get a lot of pushback from certain agents we use, but I think when you can give them a frame of reference and as the data evolves, show them this is a very personalized approach for you, they've been more likely to adhere to the regimen I recommend to them.
Yeah, that's great. Uh, Another question, just thinking about patient selection, how do you think of where FFRCT fits, where plaque fits, which patients are you using these different tools on, and which ones
Yeah.
together versus separate?
Yeah, it's a great question. I think there's data to support that everyone, abnormal FFRCT or not, could benefit from plaque tool. Clearly, Cara showed us that reimbursement may not agree with that, even though it probably should. But I think to start, anyone with non-obstructive CAD, I think benefits from it who has plaque. Meaning they have to have some level of plaque to quantify, because now, even calcium scores of 0, using that as an example, and they have plaque, you now have an objective data point to tailor your therapy. We never had that before. I never knew what to do with these non-obstructive, non-calcified plaques. So now I think we're moving into an area where we do have a target for those patients. So I think that's important. Even patients with a lot of calcified plaque, it's beneficial if it's not obstructive. You're going to know what their overall burden is, how much calcified, how much non-calcified, how much is vulnerable. So those are beneficial as well. And I do see value even in FFRCT positive patients, because they may have an LAD lesion that's FFRCT positive. We can look at the plaque. You talked about planning for intervention. We see value in that as well. I think you can see it in a more meaningful way. But then you can also look at the other vessels. So I think there's so much work to be done in this space with quantifying plaque, even quantifying plaque in patients with prior PCI to look at their algorithms and how we might change treatment strategies for them. So I think most patients you see as a reader would benefit from it. It's just what's going to get reimbursed and how we go about it will likely need more data, and time will tell how it goes. But I see value in virtually all patients who come to the CT lab for the tool.
Very helpful. This next question is really, really thought-provoking, so maybe all three of us should give a perspective on it. Does the ability to quantify plaque and FFR now open the window for screening with coronary CT?
Do you want me to go first, Tim?
Yeah, why don't you go, and then I'd love Cara's thoughts on maybe just the current realities, and I'll talk a little bit about what HeartFlow's thinking in the future as well.
Yeah, absolutely. I think I don't know. I mean, like I said, we see these patients with 0 calcium scores. They show up with events, or they have a lot of non-calcified plaque. And are we doing them justice with a preventive approach to say, your individual risk is low? Now, a population level, a little different. Calcium scores of 0, the power of 0. I believe in that. But when someone sees you in the office, they want to know, what is my risk of having an MI? And I think this allows you to really tailor that in a precision-based approach. Reimbursement, other things Cara can comment on, but I absolutely believe this could be the future as we move forward and as data evolves.
Yeah, I'm in agreement with Dr. O'Neill that this is definitely the future, and the data is going to evolve this. Currently, the current environment is that the Medicare program, unless added via the United States Preventative Services Task Force or Congress, does not allow for a screening benefit for anything that doesn't have a sign or symptom of the disease. So currently, there isn't a screening benefit for CAD. The patient has to be symptomatic in order to qualify for diagnosis and treatment under the Medicare program. That is part of the original law that set forth Medicare. And which is frustrating, but also sets, there is precedent for adding screening for specific items to the Medicare program, and then at the state level mandates for commercial payers. The most recent example of that is low dose CT for lung cancer screening. That is now a screening benefit that was added to the Medicare program, and commercial payers are starting to pick that up as well for certain high risk patients. I see that as something where, as this technology and the data evolves, and the data showing benefits in an asymptomatic population, there are pathways to get this added. We just the evidence required is rather steep, and it does need you do need to show a specific benefit, but there is a pathway there, and I think that's where this is all going.
Yeah, those are both really, really great perspectives, and I'll just say we certainly share the enthusiasm for the opportunity. The unmet need exists where many patients, about half of MIs that occur in patients who never had symptoms to begin with. So how can we get better at preventing that from occurring? Uh, None of the assessments today give all these insights of thinking about non-calcified plaque and plaque features and delta FFRCT, which we know is a huge risk factor, and all of these combinations of anatomy, physiology, and plaque for the patient. And we've done quite a bit of research at HeartFlow, published some of this, looking at how do you really leverage all these quantitative insights from CT and actually predict the risk of a patient and predict the risk they'll have an event. So that's where we see a lot of this going. But as Cara mentioned, it's going to take the right evidence to build the pathway and build the ability to actually have it paid for the broad population. Certainly, many of these things could be done in a cash pay basis for those who can afford it. But if you believe in really the equity of healthcare and making things accessible, we have to go down the full path of making it available to more people. And then another great question from Dr. Beatty. Dr. O'Neill, maybe start with you on this one. Will we see CT being used more for follow-up to treatment and looking at what happens over time for the patient?
Yeah, that's a great question. I think a lot of that is, as you said, to be determined. The data is evolving. We need guidance in this. But you're absolutely right. I mean, the patient I showed you with the non-obstructive low attenuation plaque in the right coronary artery, and then other examples where patients had events. Are we going to go and see and look at this plaque regression and see what's happened? Are we going to be doing prophylactic PCI? I mean, the data is just coming at us very fast in this. So I think eventually we probably will get to that point. I just don't think that we're there yet from a payer standpoint and data-driven approach to do that yet.
Yeah, I think that's exactly right. At this point, the Medicare LCDs explicitly exclude surveillance, which is, so unless the patient's disease progresses or they have a new symptom, under the current policy, multiple CTAs and or plaque analyses are not allowed. I do think that is going to evolve as we get better and there's more data on tracking plaque longitudinally.
Yeah, so clinically, it's of huge interest. Obviously, it's a really great way to think about precisely quantifying and tracking change in disease in response to therapy. We're seeing more pharmaceutical studies incorporating this, more ongoing evidence. But I think it is worth noting the reality today of when it could be ordered or not for a patient in the current reimbursement world. Great. Well, I'll leave just a couple seconds if there's any more final questions. I think we covered everyone that came in. They're really great questions and discussion. And thank you so much to Cara and Dr. O'Neill for your presentations. It was really insightful and hopefully brings some new information to light in this exciting growing field. I've been working with SCCT for 14 years. I've been at HeartFlow through that time, building these technologies, and I'll say there's never been a more exciting time than right now for coronary CT. And it's a result of all of this work on the evidence advocacy work to create payment and all these new technologies. So thank you all for joining and appreciate all your time today.
Thank you.